Okay, Mayor, we're good to go.
All right, thank you. Good evening and welcome to our COVID vaccine information webinar. My name is Jessica Day and I am the mayor for the town of Knightdale. We're glad that you could join us and we are pleased to partner with WakeMed and Wake County Health and Human Services to bring you this online forum. We are offering tonight's webinar because we know there's still a lot of vaccine hesitancy out there. This is our way of making sure you have the information you need to be able to make the decisions to move forward and to get the vaccine, or at least to better understand it. Our two presenters this evening are experts on COVID-19 and the COVID vaccines. First, we have Dr. Chris DiRienzo, is the System Chief Medical Officer and Senior Vice President of Quality at WakeMed Health and Hospitals. As a member of the system's senior executive team, Dr. DiRienzo's responsibilities include clinical transformation, population health, value-based care, continuous improvement, quality and patient safety, and medical staff services. He is also a practicing neonatologist, a senior scholar with the Stanford University Clinical Excellence Research Center, and serves as a board advisor to both Premier Inc. and Mercy Health. Next, we have Dr. Jason Wittes. He is the pharmacy director for Wake County Health and Human Services, which works to address some of the most pressing public health issues in our community of more than 1 million residents. He and the Wake County team helped write the plans for one of the largest mass vaccination programs in the entire state. He continues to serve on the COVID leadership team as the Section Chief of Clinical Operations for Wake County's COVID-19 team, helping respond to the frequently updated guidance and strategy as the pandemic evolves. Dr. Wittes was selected to be a Robert Wood Johnson Foundation Clinic Scholar as part of a 3-year grant focused on health equity, clinical leadership. His clinical area of interest include infectious disease and behavioral health. He is a graduate of the University of Rhode Island College of Pharmacy. Dr. DiRienzo, Dr. Wittes, thank you both so much for being here with us tonight.
It's a pleasure to join you.
Thank you. Before I turn the program over to our experts, I want to take a moment to review tonight's ground rules. First, this is a community event, so please be respectful to other participants in your actions and your words. Second, remember that we are all learning. So please don't hesitate, anyone who is watching, to be curious and send us those questions. Finally, tonight's webinar is scheduled to end at 7 p.m. We will do our best to answer all of your questions during the Q&A portion, but in the event we run out of time before we get to all of them, please contact your health provider or call Wake County Health and Human Services. That number to call is 919-250-1500. Again, that is 919-250-1500, and a member of their public health team will assist you. Thank you for being mindful of these guidelines. And now at this time, I am going to turn it over to our guest. The floor is yours, Dr. DiRienzo and Dr. Wittes.
Thank you, Mayor. I think we can skip forward a couple of slides and jump right in. So I think the mayor covered this slide and pointed out, Jason and I are here to engage with you, both those who are live tonight, those who've asked questions in advance, and those who are watching this maybe a couple days or even weeks later. We really appreciate the chance to get to connect with communities and share the sort of fact and separate that from fiction around vaccines. Why are we having this conversation? I mean, you and I both know that COVID transmission has gone through a couple of peaks and valleys since we started this battle about 1.5 years ago. And it all comes down to this tiny viral particle that we can transmit from person to person. If you flip to the next slide the core reason that COVID has been the global pandemic that it is as you see at the bottom right there, it's an entirely new human pathogen. So when we were little, those of us who were born after the 1970s were vaccinated against measles. You see measles there in the upper left-hand corner. That vaccination gave us antibodies against the measles virus. So were we to run into measles today, we'd already have antibodies ready to fight it. Chickenpox, if you were born after the 1990s, you probably got a chickenpox vaccine. If you weren't, you got chickenpox when you were a kid. It was miserable. You were super itchy. Some people get extraordinarily ill, but many don't. And so if you run into the chickenpox virus today, you've got an antibody for it. COVID, though, was totally new. When it sort of entered the global transmission spectrum, there were nobody with antibodies to it because none of us had ever encountered it before. Thus, you really have one of two ways to develop an immune response, either develop a vaccine or get sick with it. And we've seen the incredibly tragic human suffering through wave after wave after wave of hospitalization and death that comes from exposing people to COVID. And thus, this brings us to our vaccination conversation tonight. On the next slide, you'll see some super sciencey cell stuff, and I promise not to go into the details on what the toll-like receptor is, number 7, et cetera, but a lot of folks ask us what makes COVID vaccines different and why could we move on them so quickly? And really what it comes down to is the platform. So the top row there, you see on the very top left, it says mRNA vaccine, and then the bottom row, it says AdV. Which is short for adenovirus vectored vaccine. Those are the two basic models of vaccine that we have against COVID right now. mRNA vaccines in the US go by Pfizer, BioNTech, and Moderna. Adenovirus vectored vaccines in the US go by Johnson & Johnson. And I wanted to just briefly sort of walk through kind of what happens with both. Because as you can see, you really get to the same outcome, which is the body develops an immune response to the coronavirus spike protein. For an mRNA vaccine, that little circle you see on the left-hand part of the slide with the black squiggles in the middle, those black squiggles are mRNA. So very early in the pandemic, scientists sequenced the ribonucleosides that encode the genes of the COVID virus and figured out in multiple tests which part of the virus is the part that generates the strongest immune response. So a series of studies were done and they discovered that the part of the virus that really our body can respond to is that spike protein, which is why you hear so much about it. Within that blob-like cell thing, the green thing that says S protein, that's the spike protein. That cell is one of our cells. So the way the mRNA vaccine works is you take a bunch of mRNA, which is just instructions to make a protein. It doesn't go into the nucleus of the cell. It's degraded fairly quickly after it's in our body, so it doesn't replicate. But the way the vaccine works is you wrap those mRNAs inside of a little fat lipid membrane, and that's what gets injected into our bodies. Our own cells then pick up that mRNA, and our cells' protein-making machinery create copies of the spike protein. That's that sort of green dart-like thing that you see popping out. The adenovirus vectored vaccine on the bottom works in a very similar way, but uses, instead of a little fat globule with mRNA inside, it uses the outside of a different virus, an adenovirus, to inject DNA into our cells. So there's no actual adenovirus DNA in the vaccine. They replace it with the DNA encoding the spike protein. That's what our cell picks up, and then it takes over our cell's protein-making machinery, makes the spike protein, and that generates the immune response. So both in the mRNA as well as in the Johnson & Johnson, what's happening is our own cells are making the coronavirus spike protein. That's a little different than other vaccines that we've tried. For example, the measles vaccine is just a weakened version of the measles virus. So there's actually chances with live virus vaccines like that you can get a very weakened form of a disease. That's not possible with an mRNA vaccine or the adenovirus vectored vaccine. These vaccines can't give you COVID. It also works a little differently from vaccines that take parts of viral proteins and inject them into us. That's more or less how the flu vaccine works. We get exposed to parts of the outside of flu viruses, and our bodies generate an immune response to them. What we seem to be finding, though, is that these mRNA pathways generate a markedly stronger immune response for a couple of reasons. That's what you see on the right part of the slide. Not only do we make antibodies, if you look down at the bottom right-hand part of the slide, that's what's coming out of that thing called the plasma cell. So our body makes the spike protein, it gets exposed to our immune system, and the immune system ramps up two pathways. One pathway on the bottom creates antibodies that says anti-S protein antibodies. So those are those little Y-shaped things that are floating around. But it also amps up something called our cellular immunity. So we have these T cells, which are like white blood cells that go out and kill stuff, that now recognize what the spike protein looks like. And so we get this sort of dual immune response. That's a memory T cell and a memory B cell. And that seems to be fairly novel with this new mRNA and adenovirus vector technology. That's why we think in the early studies we saw incredible responses from the immune side. On to the next slide. Important also to point out the process these vaccines followed. The EUA, or the Emergency Use Authorization, is not experimental. I've heard a lot of folks call it experimental use. It's not experimental, it's emergency use. And it exists, as you see through the bullets here, because the FDA recognized that when we go through these declared states of emergencies, we need an expedited pathway to move things through the same standard clinical trial pathways. So both of the mRNA vaccines, Pfizer, Moderna, in addition to Johnson & Johnson, had very, very large clinical trials on the order of 30 to 60,000 people after two preliminary trials looking at dosing and looking at safety. So there weren't, rushed to use, they weren't rushed to et cetera. And EUA is not a full FDA approval. As you know, Pfizer received its full FDA approval at the end of August. We strongly expect the others to receive that shortly. And frankly, at this point, there's probably been more analysis on these vaccines and the billions upon billions of people worldwide who've received them than almost anything else the FDA would look at for full approval. And then finally, note that there's no process within the EUA where corners are cut. The level 3 studies, the phase 3 studies, were still extraordinarily large, and especially in post-marketing, because we've done so much emphasis on asking folks to report. These have come under exceptional scrutiny and continue to be proven safe and exceptionally effective. On to the next slide. Here's some of the data that represents that. I won't read the statistics to you, but these are all pre-Delta wave numbers that showed a dramatic reduction, even in asymptomatic infection and transmission with vaccination. The one, though, that I will point out, because we're seeing it now in the Delta wave, is the second to last row, talking about the rate of adult vaccination impacting kids' positivity. There was a study that was just released within the last few days showing that in the middle of this Delta wave, communities that have markedly higher rates of adult vaccination are seeing markedly lower rates of child transmission. And some of the hardest hit areas across America have been those that have had the hardest hit areas for children have been the areas that have had the lowest rates of adult vaccination. On to the next slide. I'm going to hand it off here to Dr. Wittes to walk through some of the deeper data and some of our local data. On to you, Jason.
Thank you, Dr. D'Arienzo. And thank you, Tana Nightel, for having me here today. So I'm going to start at a global perspective and then go to a more local perspective and actually zoom in on some real data from the Tana Nightel, because that's what we're here for, and we can provide that level of data. And I think it's important. So this came out in the end of July from the CDC, and it basically shows the reduced risk of symptomatic COVID infection, hospitalization, and death in vaccinated versus unvaccinated people. So what does this mean? So your chances of getting the disease, your chances of contracting COVID, it's an 8-fold reduction in fully vaccinated people versus unvaccinated people. And fully vaccinated is always defined as if you're getting an mRNA vaccine, completing 2 doses and 2 weeks after, 14 days after your second shot. And for J&J, it's 2 weeks after your one and only shot. So just want to point that out there. When you're looking at data and when you're seeing things that are put out, that's what that means. Hospital incidence rate, hospitalizations, or your chance of being admitted into the hospital or having to present to the hospital, is a 25-fold reduction, and as well as another 25-fold reduction in death rate in those who are vaccinated versus unvaccinated. But what does a 25-fold, what does that really mean, right? That's not a percentage. For me, that's not really helpful if I'm a pharmacist counseling my patients. So let's go to the next slide and we'll show you some actual percentages. So North Carolina, this is using across North Carolina data. The state DHHS, Department of Health and Human Services, came out with what they call an attack rate. So what is the risk of getting COVID-19 for people who are vaccinated versus unvaccinated? And unvaccinated people are more than 4 times or 400% more likely to get COVID-19 as vaccinated people. So that shows, a risk that, I'm not willing to take personally, because of the 400% increase when you look at vaccinated versus unvaccinated. And that's why I'm thankful that I am vaccinated. And that's why I encourage everyone, friends, family, loved ones, does not matter if you're willing to talk about it. I'm willing to have a conversation with you about getting vaccinated. In the next slide, we talk about death rate. So vaccines, these vaccines were never, in most vaccines, treatments, all the medications that I store in my pharmacy are not 100% effective. So the data that Dr. DiRienzo shared earlier did show some really promising numbers, right? We were seeing success efficacy rates in the 90s. Unfortunately, we were not fully vaccinated as a global, this is a global pandemic, right? You don't have, those words are interchangeable. You don't have to say global when you say pandemic. And we're really trying to prevent hospitalizations and death. And Dr. DiRienzo is going to go into a little bit more about that later in the presentation. But this slide is showing a 5-time or 1,500% decrease in those who are vaccinated versus unvaccinated in the likelihood to die from COVID-19. And that is just an astonishing percentage that needs to be noted. And this is across the state of North Carolina up until the end of August. Next slide, please. So now let's start talking about some more local numbers. So this is an image of Wake County and the case rates by census tract. So early on in our plan, we realized that we were going to need to address equity, address providing vaccines to historically marginalized populations, and where transportation is an issue, and really trying to address that. So census tracts really break it down slightly differently than zip codes to get a more hyper local understanding of the people who live there, their needs, and while it's not all encompassing, it's not one size fits all, it helps us from a public health perspective apply the necessary help that those populations might need. So the darker the color, brown, the worse the case rate. So if you look, sort of the west part and north part of Raleigh going down, what sort of left side of the graph, or western hemisphere of it, you're seeing case rates much lower. And then I'm going to show you a slide in a little bit that's going to show you vaccine rates. And those sort of mirror lower case rates, mirror higher vaccination rates. And you can see Nightdale on this, but no need to take out your magnifying glass. I'm going to get there in a second. So next slide, please. So here's what Nightdale looks like as of the end of August. So these are the 6-ish census tracts that we have. And you see we're predominantly darker brown. So 675 to 1,335 people per 100,000 people. So what does that rate mean? It doesn't mean necessarily that there's 100,000 people who live in that census tract, but a way to sort of norm or normalize the data across, because I'm going to compare Nightdale to Raleigh in a second. What does that look like if 100,000 people were there? And out of every 100,000 people, what's the range that you would expect of positive people in that census tract? So you can see we have some work here in terms of positivity rate in this area. Next slide, please. And then comparing it to Raleigh. So North Raleigh, all the way down to sort of southwest Raleigh, shows a slightly lower case rate than Southeast Raleigh, and then wrapping up to Northeast Raleigh, higher case rate. And we'll see in the next slide, higher vaccination rates. So the darker the blue, the better vaccine rate. So tier 5 being the cream of the crop, if you will. That's what President Biden set forth. At 70% of the US population with at least one dose, knowing that we will get 3 to 5 weeks later, depending on when people got their vaccine and what vaccine type they got. You know, Pfizer, you have to wait 3 weeks, Moderna, you have to wait 4 weeks in between doses, showing a much higher vaccine rate. You know, you overlay that on top of the other chart. I wish I had that graphic pulled up. You'll see a trend down in the case rate. And here again, the darker red are tier 1, so 12 to 45% with at least one dose. And those are the same exact census tracts that match up with where we saw higher case rates from a county perspective. So now let's flip over to the next slide, please, to Knightdale. So Knightdale, sort of a West Coast, East Coast thing going on. So tier 1 on the right side here is 12 to 45%, and then tier 3 to the left, which is 55 to 60%. So still below our targeted, our targeted vaccination rate that we want to see across the board. So, and why is that important? What does it actually mean? It's critical because we, when we first started our fight against COVID, we weren't worried about Delta per se, right? Here in Wake County, in the town of Knightdale, we were still fighting Alpha. And the higher vaccinated areas globally are showing less chance of variants forming. So you hear all these variants and all these Greek letters, and I feel like I'm back in a fraternity, pledging again. So what does that actually mean? Every time a virus, bacteria replicates, spreads, it's a greater chance for a genetic mutation to take place. It's a greater chance for it to deviate and create one of these new variants of concern, variants of interest that you might have heard from the CDC. But let's compare Knightdale to Raleigh for vaccines. Next slide, please. And here you see again, so the data is showing you higher rates of vaccine, lower case rates of COVID. And I just thought it was important that we see all these global Johnson & Johnson maps, or you see, universities putting up papers, but what is actually happening in my community? This is what's happening in our community here. Next slide, please. The vaccine is incredibly effective. It prevents hospitalizations and death. It decreases the likelihood of someone else infecting you, and it decreases the likelihood of you infecting someone else. And a key differentiator, and Dr. DiRienzo is going to go into this in his part of the, wrapping us up in a few slides here, where a key differentiator between Alpha and Delta is that Alpha did not grow at a faster rate in your nasal passage and your mouth. So it was harder for you to spread it as a vaccinated person. And unfortunately, because this variant learned and adapted, just like humans, viruses, as small as they are going to learn to adapt and survive. Next slide, please. So what are some common side effects? I got my COVID vaccine. I sort of had to put my money where my mouth is and say that it was safe and effective to use. So I was the first one in Wake County Health and Human Services to get their shot. And I can tell you that my #1 side effect was injection site pain. So where they stuck me was pretty painful. I, however, did not follow and heed my own advice, and that I did not exercise my arm. So when I received my second shot 3 weeks later, I made a fool of myself, made myself look like a little helicopter, but moving my arm around greatly reduced that risk. And risk of injection site pain. But that's the same for any vaccine, right? So if you get your flu shot, if you move your arm more after you receive it, less injection site pain. Also, some other key things are applying a clean, cool, wet washcloth over the area, ice, and then making sure that that is safe. And then throughout the rest of your body. So those are some side effects that my wife experienced after her shot. So she had some fever, some chills, some tiredness and headache. They resolved within 24 hours. And to reduce discomfort from the fever, make sure you're hydrated, make sure you dress lightly. If you need to, you can take Tylenol. So Tylenol is a great medication that we typically advise in any situation where you might have fever, chills, or tiredness or headache. So next slide, please. And what about long-term safety, the benefit versus the risk? So COVID-19 can lead to serious illness, long-term complications, even in younger people and those without underlying medical conditions. Unfortunately, as much as Dr. DiRienzo would love when a patient presents to the hospital to be able to figure out the outcome of any infection, whether that's, I'm presenting with trauma to the head, or if I'm presenting with a COVID infection, what is my outcome going to be? And we don't know what it's going to be. So we know some higher, some understanding of what some underlying medical conditions are that would put me or you at a greater risk of developing a more serious infection. But the best thing you can do to sort of avoid that, needing to have that conversation, is to get vaccinated. The vaccine's most common side effects are not as persistent nor as intrusive as the effects many people experience with COVID. So to a point earlier made, the vaccine now has not only been well studied, tried, been FDA approved, it has shown that there are no long-term side effects of it, whereas with COVID, we have something called long COVID. We don't know what those long-term side effects are going to be of COVID. These are known. I might have a sore arm. I might feel tired. I might have, so that's the risk versus benefit ratio that we talk about in the medical field. Or really anything you do in life, it's a risk versus benefit. It's going to rain. Should I take my boat out? I don't know. That's what we're talking about here. Even post full approval, the FDA will continue to monitor the safety, effectiveness, I wanted to say efficaciousness, and product quality of the vaccine. So that's something called phase 4 studies, and that's always being done for all drugs, vaccines, medical devices behind the scenes. And that's where VAERS data is being reported up to. It's being reported to the manufacturers. And then there's loads of really smart biostatisticians, epidemiologists, medical professionals who are sifting through that data and figuring out, is there a statistically significant side effect that pops up, or a new indication that pops up for certain medications. So that is always happening. And that's why you see that in different medications. That's why you might see warnings go on or things to that effect. So it's happening, and it's really great that it's happening. Next slide, please. And now it's Dr. DiRienzo's turn. Thank you.
I will pick it back up here and then take us home into the Q&A. This is a common question that we've heard around, everyone around me is vaccinated. If I'm unvaccinated, it's only me who I place at risk. Next slide. I think we have to remember there are folks in our communities who can't get vaccinated right now. Children under 12 have no vaccine option. And while, yes, generally children have more mild disease, we absolutely have hospitalized pediatric cases in North Carolina and across the nation. There are some folks who have a truly allergic reaction to the vaccine. And if you've had that kind of allergic reaction, they're exceptionally rare. But they do happen, then you may not be able to get dose 2. And so you wouldn't get fully protected. And so every day around us, there are folks who, if we choose to be unvaccinated, we're also putting at risk. Next slide. And that risk has only dramatically increased with the Delta variant. The viral load, and so how much virus is stuck in your nose, this preprint study in Nature showed about 1,000 times higher virus in the nose of people with the Delta variant, which leads to it becoming much, much easier to spread. Next slide gives you a visual of what that looks like. And so if before we had a small cloud of viral particles around us, if you're infected with Delta, you have a massive cloud of viral particles. We're seeing that clinically present. With wild type COVID a year ago, it might be 1 or 2 people in the household who got sick. Now it is family after family after family. I was rounding yesterday with our team in the Peds Emergency Department, and entire families were presenting for care. That's what happens when you have this significantly increased degree of viral transmissibility. Next slide will give you a little bit of a comparison. So the original COVID strain, you see there on this little graph, comparing how many folks, at most, one person sick could infect. And this is from the World Health Organization data. The original strain of COVID, at most, we thought could go from 1 to about 3 people. You can see that's more than the 1918 flu, but less than some of the extraordinarily contagious things we've seen, like measles. The Delta strain of COVID, the R-naught, the number of people who one sick person can infect, maxes out at 7. And so that's more than twice the amount of spread that can happen. And that is reflected in the dramatic speed that we see Delta waves move through communities. The next slide gives you a sense of what that's looked like in other communities. We saw in the middle of the summer, these headlines coming out of Arkansas. We saw them in Mississippi. You see Utah. We saw it in Idaho. And then unfortunately here, we've seen a similar dramatic spike right in Wake County. Next slide will give you a sense of what that's looked like here at Wake Med. So the graph in the top is the trend of all of the patients who've been hospitalized at midnight since back on April 1st who are confirmed positive. So not counting folks who were waiting on a test for. Back in January, we peaked out in the 160s, 170s. Intraday was about 180. And then you can see the slope leading up to it was sort of a gradual climb. Back on about July 15th, we hit a dramatic spike. And you can see we peaked out, the number isn't even on there, but it was over 200 about 2 weeks ago. And that came at us faster than anything we've seen throughout the rest of the pandemic. And you can see this has been largely a spike of the unvaccinated. These are actual numbers from midnight yesterday. 91% of our hospitalized patients were unvaccinated, 91% of patients in the ICU unvaccinated, 89% of people who are on life support unvaccinated. There is incontrovertible evidence that this vaccine is protective against the most severe outcomes. And our lived experience is showing it on the daily. In early August, we did just a quick comparison. And going back to January, before there was wide vaccine penetrance, our average ICU patient was in their 70s or older. Now they're in their 50s. This is hitting people extraordinarily hard, and it's hitting you markedly harder if you're unvaccinated. Next slide. There are a tremendous amount of resources available within Wake County. There's just a few examples listed here. But you can get a COVID vaccine walking out your door to just about anywhere. Retail pharmacies, the supermarkets in town, you name it. There are many, many options for any vaccine you want, be it an mRNA vaccine or a Johnson & Johnson vaccine. Anything that's approved in the US, we've got here locally, and there is plenty of supply. I saw the data presented a little bit earlier today. In Wake County, about 73% of people who are eligible, so anyone over the age of 12, are now fully vaccinated. That is an incredible place to be, but we know that there's 1.2 million people in Wake County. And so if 28% of our population is still unvaccinated, that's hundreds of thousands of people who are at risk of hospitalization and dying. And we know that we can fight that. On to the next slide. I think that brings us into the opportunity for Q&A. We've left about 25 minutes, and it's always a really good conversation. So Mayor, I think we will hand it back to you, and we're looking forward to engaging in some dialogue.
Great, that sounds great. This has been such a great presentation. Thank you both so much for the valuable information that you've been able to share with us this evening. And as you stated, we're going to use this time we have left to answer any questions that have been submitted. Dr. DiRienzo and Dr. Wittes addressed many of the questions we received in advance during the presentation, but we will make sure to answer as many of the questions that have come in again over the next few minutes to make sure that we are getting that information out. As we proceed through the questions that have been submitted, please use the Q&A feature to ask additional questions you may have, anyone that's watching, and we'll do our best to get to them before we wrap up at 7 p.m. this evening. So our first question for you is, why are people who are vaccinated still getting COVID-19?
terrific question. If you look at any vaccine, really any treatment that we have in medicine, it's never 100% protective. And so even a vaccine that's 99.9% effective, that would still be 1 in 1,000 people who would wind up getting sick. And with 1.2 million people in Wake County, that's winds up being a big number. That said, really the core of that question is how much less likely am I going to be to get not just sick or not just test asymptomatically positive, but to wind up in the hospital or die from this disease. And I think the evidence we've shared tonight is overwhelmingly in favor of vaccination being protective against those most severe outcomes, in addition to being protective against ever testing positive.
Thank you. Our next question is, how many other mRNA vaccines are in use and how many of them are not for COVID?
Sure. So I'll start, Dr. D'Arienzo. There are currently only 2 approved mRNA vaccines, and I'm sorry, one is fully FDA approved, one is approved under emergency use authorization. They're both to treat COVID. Ironically, I gave a lecture to our emergency preparedness and public health preparedness team November of 2019, talking specifically about mRNA vaccines and the research being done on them. Mainly, that whole research was focused on universal flu vaccine. So I get my mRNA vaccine for the flu, and I don't have to go annually to go get it, or I can go at a much less time interval. So currently, those are the 2 only approved mRNA vaccines. However, I think due to the efficacy of these vaccines and real world proven track record, they are now going to get the funding that they deserve and need to greatly expand our mRNA vaccine arsenal, if you will. So these are the first, but they will certainly not be the last. I know several drug manufacturers are initiating trials of mRNA vaccines for a whole host of vaccine preventable diseases that people have hoped. So HIV, flu, things like that. So I think we're just on the precipice of sort of the world of mRNA vaccines. The beauty of them, they're not cultured in, like the flu vaccine, they're not cultured in an egg, less chance of genetic mutation even when they're being produced, and they can produce very quickly as opposed to vaccines that are produced in human or not human, I'm sorry, egg proteins from chickens, specifically for the flu. So that's a huge advantage that they have over some of our traditional vaccine production lines. I don't know if you have anything else you want to add, Dr. D'Arienzo.
No, that's a terrific answer.
Thank you. The next is, if I have previously had COVID, do I have antibodies and do I still need to get the vaccine?
Again, a terrific question. The CDC absolutely still recommends that folks who have tested positive for COVID get vaccinated. And so then you might ask why. There's good evidence that if you look at the spectrum of people who test positive for COVID, some seem to have a really robust immune response that can persist for months. Others, for whatever reason, don't generate much of an immune response at all. And the immune response that we generate, some folks seem to develop an antibody to the outside of the COVID virus, which is not the spike protein, and it doesn't seem to be as powerful a neutralizing antibody. So there are components of folks who we've seen evidence show are more likely to get COVID again. So there was one big study came out of Britain that looked at just a universe of people who tested positive for COVID. One group then went on to get vaccinated, and another group didn't. They then looked at who got COVID again. And the folks who were vaccinated were 2.5 times less likely to test positive for COVID again as those who were unvaccinated. That's as clear as data as I can find, that even if you've had COVID, vaccination will reduce your chance of getting sick again.
Thank you. How many people have died from the COVID vaccine?
I will take the first answer at that one, Jason. It is difficult to impossible to know for sure. What I can tell you is 640,000 people in America alone have died from COVID itself. They've been in our hospitals at WakeMed. They've died in hospitals around the country. They've died at home. They've died in nursing homes. And so nothing in life is without risk. There are reports of folks having severe allergic reactions to COVID vaccines. But when you look at the potential for those risks, if you look at the whole universe of adverse reactions, the things that are reported in VAERS, the likelihood of that happening is so incredibly low compared to the likelihood of getting COVID being so incredibly high that it really comes back to what Dr. Wittes and I were referencing earlier, which is your benefit versus risk. And again, just doing the math on the COVID vaccine and looking at the entire universe of folks who we've seen with disease, it is so heavily in favor of benefit that I can't recommend it any stronger. And as Jason said, I've been vaccinated. Everyone eligible in my family has been vaccinated. My extended family has been vaccinated, and we'll be lining up for boosters as soon as they're available as well.
Yeah, thanks. I'd like to add as well that, you know, the VAERS system is great. However, it's flawed to look at it and just look at the raw data now in the way that it is. I could go on VAERS right now, say that I had a vaccine reportable side effect, and I turned into Barney the dinosaur. So if someone were to look at all the adverse events, there would be one Barney the dinosaur as an adverse event. And I hope that's not trademarked for that. But you get what I'm saying in the sense that, you know, it's a great reporting system to put in, but the problem is that it's in the form where you're looking at it now, it's all the raw data. So I believe that there have been around 0.002% of those people who have been reported to have received the vaccine and then reported to VAERS that the person had passed away. Now, what is that related to? Is it because they got hit by a bus after they got vaccinated, or do they have underlying medical conditions? That's why these post-marketing surveillance studies are taking place, and that's why biostatisticians, epidemiologists are looking through that data and trying to find if there's a statistically significant increase in anything, whether it's death, side effects, adverse events, gender, race, demographics, all that stuff being looked at. But that's why I don't, or anyone but as a pharmacist, I don't look at the package insert, the pre-study data that everything's being reported. I look at what is being reported as side effects, what's clinically significant, what's statistically significant. Do people withdraw from the study? Why do they, you know, and then all that data is not sort of sifted through and cleaned up in the VAERS system. So that's a flaw, I think, in the system of having it publicly available, but it's publicly available. So you can go, you can look, you can pull up all the data that you want. But I would just say, take that with a grain of salt, because knowing that it could be reported from anyone. There are certain instances, to Dr. Arienzo's point about if someone has an anaphylactic reaction. So that's a known side effect of the medication that we take very seriously. And we have the safety precautions at all of our sites, and I would imagine every site offering vaccine, so EpiPens, Benadryl, things like that. And if that happens at one of our sites, we report it in the VAERS system. So if you are on site with us and something happens, we are required to report that in the VAERS system. So it is capturing absolutely everything. And it's not for me to say at the time whether or not it's directly related to the vaccine. You know, odds are we can say that an anaphylactic reaction is now, because that's been proven. But other instances, we don't know. And that's why it's reported there. And then that's why that studies still happen. And it's not just for COVID. It happens for the COVID vaccine. It happens for all vaccines all the time.
Thank you. The next is, what process is in place to provide vaccinations to those who don't have access to private or public transportation? How are those who don't have internet access being supplied information on the vaccines, as far as where to get them, how to get them, and locations?
Mayor, that's an excellent question. And I think in every community, there's been a slightly different answer. And over the course of the last 6 months, there have also been lots of different options available. So we've, with Wake Med, through the Sister Circle partnership, partnering with Wake County, had a number of strike team events. And I've seen, personally at vaccination sites I've worked at, family members bringing in other family members who couldn't drive and didn't have access to transportation. We had folks who have no homes walking to sites, and we set up sites that could come to them in a number of different other instances. So I think if you know of someone who wants to be vaccinated and doesn't have access to transportation, et cetera, you can reach out through your community, you can reach out through Wake County Public Health, you can reach out to us at Wake Med. We as a healthcare community want to help find a way to get that person their shot.
Yeah, and I'd just like to add that, through the strike team work, we also are, we're canvassing in neighborhoods where vaccine rates are particularly low through the census tract work. At this time, Knightdale is not one of the focused census tracts, but we're it's on the verge of that's where we're going to go to next, and that's literally going door to door, explaining some of the myths and facts versus fiction, just like we're doing here. And then if someone wants their vaccine through some of those strike team work, they're getting vaccinated right then and there at their front door, at their house. So we are doing our best effort to meet people where they are and meet people where they're needed. But that's a very manpower intensive plan, right? So it's not just setting up a drive-through and letting everyone drive through. So it's going to take some time. But to Dr. Enzo's point, if you know someone, call us. We will do our best to make sure that an accommodation is figured out. So everyone who wants to get their vaccine, we're in the business of access and getting people what they need, not in the business of blocking that. So thank you.
Thank you for that answer. So going into the side effects, what is the underlying cause of headaches after receiving the vaccine?
Ooh, that's a tough one. I don't know that I can draw a causal link from anything specific. What I can say is after you get a vaccine, remember your immune system is ramping up a response. And so it is not uncommon for folks to develop a low-grade fever. I developed a low-grade fever for about 24 hours. And as your body, the immune system ramps up, you get some sort of inflammatory that causes a fever, that may cause a headache, that can cause some muscle pain. What it doesn't cause is COVID-19. So to be super clear, you explicitly cannot get COVID from the shot. And so any side effects that you're getting generally are from your body's reaction to developing up that immune response.
Thank you. I have a question about children and the risk of MIS-C if they become ill with COVID. I understand this is rare, but how many cases have we seen in North Carolina and Wake County?
That's a terrific question. I'm a pediatrician by training. I can't give you a quote on the number in Wake County, although I can confirm we've absolutely had cases reported here, but I can't give you a specific number. The risk of MIS-C is absolutely very small. And we know that vaccination, especially in that 12 and older group, is protective against it. That was one of the things I took into account when talking to my vaccine eligible age children about receiving their shot. And so know that it's absolutely a recognized follow-on from COVID. We don't exactly know why it happens, but children can get exceptionally ill with it for sure.
Thank you. Our next question is, can you confirm how effective masks have been in preventing COVID-19?
Goodness, I don't have a great answer for that. I can't put a number on it. What I can say is each time we saw progression to masking and reaching kind of critical levels, we saw deflections in case count. And if you look at just the physiology behind transmission of this virus, we know that the majority is droplet. There's some evidence for airborne as well. And so if we are wearing a mask appropriately, that's appropriately fitting, we're keeping our droplets in and keeping other people's droplets out. Is that going to be 100% effective? But we've seen evidence that clearly isn't 100% effective. Even an N95 mask, it has to be worn correctly and it has to be fitted to your face and so on. But combined with things like appropriate ventilation and distancing when indicated, these are all have been clearly shown to be effective transmission reducers. However, the single best thing, unquestionably, is vaccination.
Thank you. Is there a shorter period of time when an individual is contagious after they've had COVID if they've been vaccinated?
Also, terrific question. We don't have a great answer to that yet on the science side. What we do know is that folks who are vaccinated and test positive for COVID tend to have a much milder illness course. And so one might then hypothesize that yes, your body would clear the virus faster, but we also know that even in wild type COVID and unvaccinated folks, there's this viral shedding that seems to go on for, in some people, weeks after they feel completely better, and we don't yet know why. We also don't know if that viral shedding is even live virus. It's just we're able to get a positive test, meaning there's viral nucleoside somewhere in there that could be dead. So long answer to your short question is we don't know, but we know that if you are vaccinated, if you test positive, which again is markedly lower likelihood, then your illness course is markedly more likely to be mild and shorter.
Thank you. The next is, will we need to get a booster shot? And why are they necessary?
So, yeah, so the booster shots are, I'm sure you've seen all in the news, and it is a key differentiator between a booster shot and an additional dose. So right now, what's approved for authorization is to administer is an additional dose of Pfizer and Mrna Vaccine to those individuals who are immunocompromised. And those are very specific criteria of being immunocompromised. Specifically because your immune response in those patient populations was not enough to the first two shots. So you needed a third shot to sort of complete your series, even though that doesn't count towards the date of completing your series, to render an immune response the same way that someone who was not immunocompromised. We're also seeing some of that same data in our elderly population. And the first thing that comes to mind is, what's another vaccine that requires a high dose or an additional dose? The flu vaccine, every year recommended for those 65 and older to get a high dose flu shot. So it's the same compound, same makeup of the flu strains, just at an increased strength for people who are 65 and older. So you elicit a much lower immune response as you age, as opposed to when you're younger. So eventually, when kids get approved, odds are their dose of the COVID vaccine might be a little bit less. So that's something that's key and critical to that. And I think right now we're sifting through the data, and the FDA and CDC are looking at the data from some studies specifically around booster doses. We are preparing here in the county to be able to meet and go live with booster doses if approved on September 20th. But I heard an interesting analogy earlier today, actually on the New York Times podcast, The Daily. So the way to think of boosters is you're boating on Lake Johnson, although I don't think that lake allows motorized boats, but my boat is sinking and I am an immunocompromised person and my life vest is not working to keep me up above the water. So someone's going to throw me an additional life vest because the first two didn't seem to keep my head above the water. And now I have it on and I can have equal immunity and equal efficacy. For me, as a non-immunocompromised person, I have my life vest on, I'm bobbing above water, but I see my straps a little bit frayed, and I see that some water is getting in, and I'm not maybe as good above the water as I was when I first got in the water. I'm still good, but I'm not all the way out of the water. And that's the data that they're looking at now. So I know that might sound like a crazy analogy, but I like to break things down that make sense to me. My mom, she needed an extra dose to be effective. I don't. So we need to see what that data shows, but just know that when that time comes for those people who want their booster shots, and that's what it's going to be called, a booster shot as opposed to additional dose, we'll be ready. It's not like how it was 9 months ago where Wake County was only getting 900 shots in at a week, and we were contemplating how long it was going to take to vaccinate everyone. So we're in a much better place, and we are also the largest hub of transfer doses. So supplying all of those resources that Dr. DiRienzo mentioned earlier in the presentation. So we are the largest single vaccine provider of vaccine in the state of North Carolina, whether that's transferring to our community partners or through us here at Wake County. So we are just here, and Wake Med is here to meet people where they are and ensure that they have access for when they want the vaccine, and whenever they want it, they can get it.
Great, thank you. Is there any new information on when vaccines will be available for children under 12?
I haven't heard any updates in recent weeks. I know we were looking towards end of this year, early 2022. Dr. Wittes, I don't know if you've got anything more recently updated than that.
That's the same timeline I've heard as well. So we'll see what happens there in terms of the updated timeline. But as soon as we have something, we will put that information out.
And this has been great. We've had great engagement, a lot of questions. I think we're getting close to the end mark, and we probably only have enough time here for one more question, but we still want to hear everyone's additional questions if you have them. So I believe the last question will be, are there fertility issues from getting vaccinated?
A terrific question, and one that we've heard a lot. And I'm not an OBGYN, but there are two governing societies for doctors who are OBGYNs. So doctors who are caring for moms who are pregnant and caring for moms who want to become pregnant. Those two societies are the American College of OBGYNs and the Society for Maternal Fetal Medicine, who specifically are looking at higher risk pregnancies. Both have come out unequivocally and strongly recommended COVID vaccination for women who are pregnant, who are looking to become pregnant, who are working through fertility issues, and who have given birth and are breastfeeding or lactating. And so I know that there's been some concerns reported out there around fertility. All of the evidence suggests that there is no negative impact, and during pregnancy that vaccination is very strongly recommended because we're seeing an increased rate of worse outcomes in COVID disease for moms who are pregnant.
I'm going to try to get one more in. If I've had COVID already, how long do I have to wait to get vaccinated?
All you have to do is wait until you're out of your quarantine window. So the CDC very early on had recommended waiting a little bit longer when we had some supply limitations. Those supply limitations are gone. So as soon as you are out of your window and you're allowed back out of your house, your first stop can go be your COVID vaccine.
Thank you so much. And I believe we were right at that 7 o'clock mark. So I thank you for joining us, those that have joined us and listened in. We hope that you have found tonight's webinar informative. As mentioned earlier, if we were unable to get to your questions, please be sure to call your health provider or call Wake County Health and Human Services at 919-250-1500. And a member of the public health team will assist you. Again, that number is 919-250-1500. Please ask your questions. You've had great questions this evening. We were able to get to most of them. Some of them we were not. So please reach out. We have representatives here that are waiting for your call to answer your questions. Thank you so much, Dr. DiRienzo and Dr. Wittes. We thank you for coming here this evening and for sharing this information and being willing to answer our questions. Thank you all for joining.